Everyone's taking some time to join on, so we're just going to give a couple minutes to let everybody get in. But I want to welcome everybody to this patient-focused webinar. I'm Shalene McHale with Insight Tech, and I'm pleased to be a part of today's virtual education event. Just give just a couple more seconds for everybody to log in. Sometimes it takes a minute for everybody to get on, and we'll be right back with you. Okay, it looks like we have a great number of attendees signed on. So let's go ahead and begin. The goal of today's presentation is for educational purposes. We are very fortunate today to be hearing from Dr. Michael Caplet from New York Presbyterian Weill Cornell Medicine as he discusses focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentations, please utilize the Q&A button located at the bottom of your screen. We will have time after the presentation to answer the questions that are asked within that chat. And I'll just remind everyone to go ahead as the questions come up during Dr. Caplet's talk to feel free to put those questions right in there at any time. Let me begin by introducing you to today's presenter. Dr. Caplet is an executive vice chair of neurological surgery and professor of neurological surgery and the director of movement disorders and pain for New York Presbyterian Weill Cornell Medicine. He combines surgical expertise with advanced training in state-of-the-art stereotactic techniques to provide patients with effective, minimal invasive treatments for degenerative disorders, including Parkinson's disease, essential tremor, and dystonia. Dr. Caplet graduated magna cum laude from Princeton University with a degree in molecular biology and Russian studies. He enrolled in the tri-institutional MD-PhD program and received his PhD in molecular neurobiology. The Rockefeller University and his MD from Cornell Medical College. Following his neurosurgery residency and chief residency at the New York Presbyterian Weill Cornell, he completed a fellowship in stereotactic and functional neurosurgery with Dr. Andres Lozano at the University of Toronto prior to joining the staff and assistant professor of neurological surgery in July of 2001. He has published over 100 articles and has edited 2 books and is the recipient of many awards. We are very fortunate today to have Dr. Caplet on with us, and thank you so much, Dr. Caplet, for presenting.
Thank you for that lovely introduction, and what little time we have left, I will talk about focused ultrasound. I appreciate everybody joining us today. This is something that I'm very passionate about, and it's not only been transformative for our patients, but it's been transformative for my practice. You know, I've been very fortunate in my career. As you heard, I started my career a few months before 9/11, actually, when I had finished my training. And so I've been in practice for a very long time. And when I started, a technique that I'll mention briefly in a minute called deep brain stimulation was actually considered experimental and was not yet FDA approved. So to have the arc of my career allow me to participate in that, to help lead, and so to do that procedure when it was still considered experimental, and then to lead an enormous number of research efforts that we've done over the years, and now to have the opportunity to bring this exciting new technology to our practice and to our patients every day, and to continue to participate in pushing the envelope with this technology with new publications and new applications that we're looking at, myself and my colleagues, both in our laboratory and in our patient clinical trials, has been enormously gratifying to me, because that's the whole reason for having gone into this field, is to really try to innovate and bring new things to our patients. And that's the reason I've been at Cornell for so many years. So thank you for joining us. And I am going to talk today about focused ultrasound for movement disorders primarily, although I'll talk a little bit about some new applications at the end. Now, as most of you probably know, the brain is composed of a variety of circuits, of connections between brain cells that serve specific functions. And when particular circuits no longer function properly, that's when we get very specific neurological diseases. So there are circuits that are responsible for mood, and when they become dysfunctional, you can have depression. There are circuits responsible for learning and memory. When they become dysfunctional, you can have Alzheimer's disease or dementia. And there are particular circuits that are responsible for movement. And that's where many of us have spent our careers as surgeons, trying to take advantage of techniques that we learn to be able to very precisely target these circuits to try to improve their function and help people with devastating movement disorders. In particular, essential tremor, which is a disorder of movement where you have a severe tremor when you go to move, but otherwise your movements are okay. But that the disabling tremor prevents you from doing many normal activities that most of us take for granted. Or Parkinson's disease, which is an even more complex movement disorder that involves a different type of tremor, a tremor that occurs at rest all the time and not just when you move, in addition to other symptoms such as stiffness and freezing and other things that make it very difficult to move in addition to the tremor. So there are circuits that influence both of these movement disorders, and that's what I've spent almost a quarter of a century trying to help people overcome. And even more than that, about 30 years doing research to try to advance treatment for these disorders. Now, as I said earlier, the mainstay of therapy when I started my career that was considered very cutting edge was deep brain stimulation, where you used surgical techniques to try to target electrodes deep in the brain to a particular area of the brain. And that gets connected to an extension wire that goes into a pulse generator or a battery that goes in the chest like a pacemaker that sends little electrical pulses to the brain. And that is still a very effective therapy for certain diseases, particularly for certain types of Parkinson's disease and other things that we treat. And I still do a lot of this procedure. It's still a very, very effective procedure, but it does involve invasive surgery, even if it's minimally invasive through a small hole. More importantly, it involves a permanent implant of a device in the brain and in the body, and a battery that has to be maintained. And for a lot of patients, the idea of avoiding having a device in their body can be very attractive. For people who do not live close to a center that's capable of managing that device and optimizing the device, which often requires frequent visits, the idea of avoiding a device and having a one-time therapy can be very attractive, so that the idea is that you can go to a center and have your movement disorder treated that day, and that's all that you need to do, and not have to do any maintenance of a device after that. That is very attractive to a lot of people. And so that is where the idea of focused ultrasound comes along. Now, focused ultrasound, as I'll explain in a second, is a non-invasive way of doing surgery. We are permanently changing some of these circuits in the brain, so that is very much like what we do with invasive surgery, but doing this in a non-invasive way without a device. Now, as I learned a long time ago, no matter what you think of that's new, someone else has already thought of some variant of that sooner. So back in 1968, this is what non-invasive surgery looked like. For those of you who remember, this is Dr. McCoy from the famous TV show and subsequent movie Star Trek. And this was from an episode where they were using a non-invasive helmet to deliver energy, as you can see, to a particular area of the brain. That was 1968. Today, we have a device that doesn't look too dissimilar to that device on his head, but that actually makes that science fiction from 1968 a reality. And so, as you see in the upper right-hand corner, what the focused ultrasound device from Insightec does is it is a helmet. By the way, I should also make clear at the beginning that while I am talking about the Insightec device, which has been transformative in my view for our practice and our patients, I personally have no financial interest in the company. I'm not a paid consultant or anything else. I am a clinical practitioner who is trying to advance the science and the clinical practice of this technology, but I have no direct involvement financially with the company whatsoever. So getting back to what I was saying a minute ago, the helmet in the upper right-hand corner that you can see, that has a series of ultrasound sources that are targeting a spot deep in the brain to send ultrasound energy. And you can see in the lower right an example of how those beams of ultrasound come at different angles through the skull and through the brain and intersect at the target that we want to hit. Each beam of ultrasound energy, as it goes through the scalp and the skull, is sufficiently low energy that it does nothing to the brain. It doesn't do anything harmful to the brain. But at the point where 1,000 beams of ultrasound converge or meet, you can deliver enough energy to ablate or destroy very, very tiny spots in the brain that are dysfunctional and that are causing these various movement problems. So it's very much akin, to the upper left-hand corner. Many of us, when we were children, used a magnifying glass on a sunny day to burn a hole in a leaf or a piece of paper. And what that did was that focused sunlight, different beams of sunlight. It focused it on a very specific spot to deliver enough energy to that spot to heat up and burn a hole in that leaf or piece of paper. And that's what we're doing here with the InsightTech ultrasound devices. We are focusing a series of ultrasound beams onto a very specific point, and that point is the target deep in the brain that is dysfunctional, that we want to stop from being dysfunctional. And so in movement disorders, whether it's essential tremor, which in this case we're targeting an area called the thalamus, or in Parkinson's disease, where we can also target this area to treat Parkinson's tremor, but there are other targets in the brain we can use to try to target to treat other symptoms of Parkinson's disease, such as freezing and stiffness. When we are targeting these areas, we are trying to heat them up to the point that you can actually destroy those little spots, and they are dysfunctional. They are essentially putting a brake on the normal circuitry of the brain, preventing it from functioning normally. So by ablating or destroying these dysfunctional, abnormal spots in the brain, we can free up the rest of the brain to function more normally, and you see responses instantaneously. So that is the idea behind the focused ultrasound technology. Now, it is called MR-guided focused ultrasound because, as you see in the upper right-hand corner, we are doing this in the MRI machine. So the helmet goes over a patient's head, and then we will slide them into the MRI machine. And as we deliver this energy, we can monitor the temperature at the target site, because the MRI is capable of indirectly monitoring the temperature anywhere inside the tissue that is in the MRI magnet. So we can use a technique called thermometry, which is an MRI thermometer, essentially, that tells you the temperature. And so we can use that to guide the ultrasound delivery. So the MRI machine will show us exactly what's heating and where it's heating and to what extent it is heating up. And we can use that information to guide the focused ultrasound to make adjustments and do what we need to try to ablate the exact spot that we want to ablate to get the best effectiveness, while leaving nearby areas that we do not want to touch alone so that we get the most safety. So that's how we combine effectiveness and safety, is by doing this in the MRI machine to allow us to monitor what we're doing in real time. That's why it is called MR-guided focused ultrasound. We are focusing the ultrasound on a spot, just like you see that the magnifying glass focused the sunlight on a spot on the leaf, and we are using the MRI machine to guide exactly how we're focusing this. So this shows you an example. A patient is put into a frame. This frame is something that holds the head in place so that you can't move. That is done under local anesthesia. We have to shave the whole head because the company is working on trying to eliminate that in the future, but that's going to be a while, because the hair follicles can scatter and unfocus these beams of ultrasound. And this is something you want done properly and safely once, and then the hair will grow back and you can benefit from this for the rest of your life. So that's why, while we all wish that we didn't have to do that, it is critically important right now for maintaining the proper focusing to allow effectiveness and safety. And as you saw a minute ago, those beams are delivered to the spot, and now you see this little dark spot where we ablate the area that we're interested in ablating. And then when we're finished with the procedure, we take the helmet off. Now, this procedure After we shave the head and we inject with local anesthesia in 2 places in the front of the head and 2 places in the back to numb you up so that we can place this, this frame or halo in a way that is not painful. Once that's on, we then put people on the ultrasound table, as you just saw a minute ago. And I'm going to play this one more time while I'm talking. And then once the head is in and the helmet is on, you go into the machine, and that's when we send this energy. Now, the procedure itself takes about an hour and a half, but you're not in the machine for an hour and a half. We will put you in for about 10 minutes, take a series of MRI pictures, then we slide the patient out of the magnet. You cannot get up. You have to stay on the table because then we have to start from scratch. But you don't have to be inside the magnet the whole time. For people who are a bit claustrophobic or just don't like being in the MRI. I've had MRIs before, and I know how it feels to be in there. You're really not in there for much more than about 10 minutes at a time. And then we slide you out, and then we make some adjustments to the targeting, and then we slide you back in. We take a few more pictures, and we do a few more things, then we slide you out again. And then we start sending low levels of energy. And so what you see here is how we monitor that energy. So you see that there's a curve here that's showing as the energy increases over a few seconds, over about 10 seconds or so, it'll reach its peak and then come down. And so this is kind of an intermediate level of energy where it reached a peak of about 47 degrees. Eventually, we want to get this to somewhere between 55 and 60 degrees, that peak. And this is in Celsius or centigrade. So that's the so-called ablative temperature. But this is a temperature that is not high enough to do anything permanent. So if you look at here in the lower right, you see that that circle is our target. That's what we want heated up. The red is what's actually being heated. So you can see that the red is heating sort of at the center of the target, but then extending a little bit more in front of the target. It's not really evenly heating around the target. It's heating a little bit more in front than we would like. So this is an example of where we can, knowing this, we can make an adjustment and then recheck this at this lower temperature and make sure that we don't start to give enough energy to do anything permanent until we're satisfied that the heating is well contained within the zone that we want to heat in all directions, side to side, front to back, up and down, so that we can maximize our effectiveness at the target and we can minimize the spread to nearby areas. And so that's the second part of the procedure. After we do the initial setups, is we do a series of rounds of low temperature heating, see what the spot looks like, make whatever adjustments we need to. And the patients are awake, so we're checking on things like speech and sensation, which are governed by connections that are right nearby our target to make sure that nothing is changing in the patient during this. And so if the patient is doing fine clinically, speaking okay, sensation is okay, everything's fine, and then we make these adjustments and the spot looks good, then we'll send more energy. And we'll start, usually when we do an intermediate level of energy, we'll see about a 50% improvement in the tremor. And then if the spot continues to look well contained, exactly the way we want, and the patient is doing well, then we'll send more and more energy to make this permanent. And so you can see here an example of 3 different ways of looking at the ultrasound. The left side is one of the main ways we look at that. And you can see that before the procedure with the so-called T2 image, you don't see anything. But then where the arrow is, that's the target. Now you can see this little white spot with a dot in the middle that the arrow is pointing to. That is the ablation zone that is responsible for tremor. And that's immediately after the procedure. And then on day 1 after the procedure, you can see that there's a little bit of white halo around that zone. That's a little bit of swelling that occurs. And that can affect some of the nearby areas. So a day or 2 after the procedure, patients can have some side effects, such as a little bit of slurring of the speech, a little bit of numbness, even some unsteadiness in their walking that might be either new or worse than it was immediately after the procedure. And that is usually because of the swelling that occurs. Because anytime you damage tissue in the body, there can be swelling. Imagine if you bang your hand at night and it hurts and it's a little black and blue and you rub it, and then you wake up the next morning, it's all blown up. That's what happens in the tissue in the brain as well. Once we've ablated, over a day or 2, you'll get a little bit of local tissue swelling. It's not all over the brain. The rest of the brain is fine. It's not dangerous. in terms of safety overall, but it can cause some temporary side effects that usually resolve over time. In the middle, the so-called diffusion sequence is a sequence we use when we're actually looking to see if people have a stroke. So that can really tell you whether brain tissue is dead or alive. And so we use that to look at strokes. In this case, we're again using it to look at this spot. Again, at the beginning, before the procedure, you don't see any abnormalities. But then you see this white spot in that area. That tells us that the white spot from that other sequence on the left is actually dead tissue, where you see the arrow, and then it gets a little more bright the next day. And then on the far right is a sequence that tells us whether there's any blood in any bleeding in the area. And you can see that there's really no bleeding. There's no dark spots, except on the second day, there might be potentially a spot or two, but that's nothing that we're concerned about. So we use that at the end of the procedure to make sure that there's no evidence of bleeding. And we have never seen any evidence in 8 years of doing this procedure and several hundred patients, we have never seen any evidence of serious bleeding. That is why early on, I decided to start sending patients home immediately after the procedure, well, an hour or two after the procedure, and not keep them overnight the way that we do for deep brain stimulation. And that has proven to be a very safe and effective way to do this. And we now have sent all of our patients home without a problem from having sent them home. And that's the way most centers are doing this now. So most people go home an hour or two after the procedure and can use the hand that they've, that they were no longer able to use before that evening. And so this is an example of how we map out the connections that I was talking about. So in green, you can see the connection that is responsible for the tremor. It's the area that's responsible for coordination and stability normally. In red, right next to it, are the connections that are responsible for speaking and movement. The connections responsible for speech are closest to the area that we ablate, so that's what we're most interested in. The connections responsible for moving the arm and the leg are much farther away in that red area, so you would have to really be into that to cause weakness of the arm or leg. But if you kind of touch just the part that's adjacent to the green, you could start to get a little bit of slurring of the speech, like you had a stroke or something, and we want to avoid that. And behind the green area in yellow are the connections responsible for sensation. And you get into those and you can get some numbness. So you can see there, so if you look in the next slide, this is from a paper that we published, one of our patients. You can see that before the procedure, on both sides of the brain, you see the green connections that are responsible for coordination and for the tremor. In red, right next to them, are the connections responsible for speech and movement, and behind are the yellow connections responsible for sensation. Before the procedure, you can see how difficult it is for this patient to draw a simple spiral or a straight line. Their hand was shaking so horribly. After the ablation, you can see on the right side of the screen, which is actually the left side of the brain, you can see that green connection is now gone. The red and yellow connections are still perfectly intact. And when that is gone or ablated, you can now see how the tremor stops immediately, and you can see that the patient can now draw a spiral and draw a straight line and use that hand. This is while they're on the table. This is not at the end of the procedure. This is on the table while they're upside down, they're making these drawings. And I'll show you that in a second. And so it is really quite a dramatic effect. And yet by sparing those red connections, those yellow connections, you can avoid speech problems and sensory problems. It is a risk. There are a small percentage of patients that can have a little bit of speech difficulty, that can have some numbness. It usually gets better in most people. It is extremely rare, but not unheard of, for these things to persist long term. Usually they're minor and not disabling, but it is a small risk, and that is what we always try to avoid to the best of our ability. So this is an example of the progressive improvement in the tremor, as I told you earlier, where you see a terrible tremor at the beginning, terrible tremor when we're doing our setups, and then the third panel on the right now is that kind of intermediate level of energy where you're starting to see a real improvement in the tremor, but we're not fully there yet. And then as we progress along to the lower right panel, we have near complete resolution of the tremor. I would say that lying upside down, writing like this, most of us who don't have tremor would not do that much better than this in the lower right-hand corner. And this is an example of a video of me doing this in real time with the patient. So this is beforehand. and you could see them trying to draw one of those spirals. You can see how the hand is really shaken quite a bit, making this very difficult. Sorry. And then you can see they were literally stabbing at the paper. And now you can see when we are hitting the right spot in real time, you can see how much better their hand is. And it's really quite dramatic. I think most of us can see how much of a difference there is there. Sorry. And you can see what they were. So what I'm showing you is exactly what they were drawing on this video in real time. So it's an extraordinarily satisfying and dramatic procedure. Now, one of the many challenges we face is trying to figure out when we've done enough. As you can see on these MRIs, there is no sign that says, this is how much you need to do. That is up to the surgeon with their knowledge of anatomy and experience. But the question is, if we've done a very nice ablation, so you can see here, this is a patient trying to draw a spiral, and he was stabbing at the paper and having a very difficult time. This was a patient in his 80s, I believe. And then you can see, following the ablation, that in the lower right-hand corner is an example of the connections. You can see the green connection is gone. You can see the nice little halo that I showed you, the white halo with the dark in the middle. And then the red connection, the yellow connection are intact. This patient did very well. Had no speech problems, had no problems with sensation, and you can see a dramatic improvement in their tremor, and we were thrilled. Are we done? Well, part of the problem is that a few months later, this patient's tremor came back quite a bit. And we have seen in our practice about a 10% recurrence rate, meaning that about 10% of our patients have some recurrence. It's not always as bad as it was before the procedure. Some patients with recurrence say, you know what, I wish it was as good as it was a week after the surgery or the procedure, but it is still much better than it was before. We don't need to do anything. But some patients, it can come back pretty severely. And you can see that now we see a recurrence of those green fibers. This is not the brain regrowing. If I could learn how to regrow dead brain tissue, I'd have won a Nobel Prize already, because nobody knows how to do that right now. What's going on is that in this prior slide, you can see that there's a white halo and then a little bit of fuzz around that white halo. So most of what we wanted to target was destroyed, was ablated, but some of that may have just been temporarily dysfunctional, but not actually fully ablated, and that might have contributed to the tremor improvement. And it's always difficult to know whether you've ablated enough or whether there's still more to do. So if somebody has 100% tremor control and a good-looking ablation and no side effects, am I done? If I do more, if I do another round and the patient starts to have side effects, you say, well, why did you do that? I was great. If I don't do another round and the tremor comes back 3 or 4 weeks later, you say, why didn't you do one more while we were there? That's always the balance. My patients often hear me say this, that my view of my job is that I don't get paid to be a cowboy and I don't get paid to be a chicken. Somewhere in between is the right answer, meaning I have to be aggressive enough so that the vast majority of my patients do well and don't need to come back, because otherwise then I would not be doing them a service if everybody was coming back because I was so afraid to do enough. But I also can't be afraid to stop if I feel like we're getting into a territory that could be problematic for a patient. And if you happen to be in the small percentage that recur, then I'm sorry, but we are able to potentially retreat. And we have now, this was the first patient to my knowledge that was ever retreated. That's why this was the subject of a publication. And now most everybody I know has retreated a few patients, and we've retreated about 4 or 5 more patients in the years since this was published. And we have always been successful at recapturing the tremor control when we've retreated. So that is an option. It's not an option that we welcome, but it is certainly an option that is preferable to permanently hurting somebody by overdoing it. So you can see here that this patient had a recurrence. We retreated that area, and now you can see this was their tremor in the lower left-hand corner after their recurrence, meaning you saw how much better they did. It was completely gone in the E panel here in the lower right. Now this is 3 months later, and that's what they went back to. And we targeted that area that was recurrent, and you can see the green is gone, and now you can see in E that their tremor is even better than it was the first time. And now this person was stable for a couple of years after this. So that is a good option. Now, what is the most recent advance? A lot of patients ask, what about the other side? When the FDA approved this originally, they only approved ablation for one side of the brain, and most insurers were only reimbursing for one side of the brain. And that is because there was concern from older literature when you would invasively put a probe in and ablate these things. There was concern that if you had side effects when you ablated both sides of the brain, they could be much worse for patients than if you only had side effects on one side. So that was why we had to do a study to see, would this approach be any different than what had been done years ago? Now, what was done many years ago was to put a probe invasively into the brain and just heat the area without knowing exactly what you were doing. You knew where the probe was, but you weren't really sure of exactly how much tissue you were heating. Here, with this procedure, as I described earlier, we actually know what we're heating. We can see in real time what we're heating and make adjustments more or less, et cetera, as the patient needs. So we all felt that because this was a more controlled procedure, that perhaps we could do treatment of both sides in a staged fashion, meaning do one side, wait a period of time to make sure that the patient has a good long-term result, that it doesn't come back, and that they don't have long-term side effects. Maybe some temporary things, as I talked about earlier, that resolve, but they don't have major long-term side effects. And the question was, in those patients who have a good result with no major long-term side effects, could we then do the same thing on the other side safely and effectively? So here you see an example of a patient, again, where we're targeting the green the first time and leaving the yellow and red alone. And you can see the ablation, the little, gray halo with the dot on the side and the little white spot showing that that tissue is dead on the left. And you can see long-term that on the right side of the screen, the green is gone, but the yellow and red remain. But on the other side, the green is still there because we didn't treat that side. And this patient had a good long-term control. And this is 3.5 years later, or a little more than 3 years later. Sorry. So now we treated the other side. And you can see that now we ablated the other side. You can see the white spot, and you can see, the progression of, with that, the leftmost panel shows that there's no bleeding. The middle panel shows the tissue is dead, and the right panel shows you that little halo with the dot in the middle that we look for. And with that, the green on the other side is gone. Now you see no green on either side, but you still see the red and yellow. And this patient had great control of both sides of their tremor. And this was one example of a patient in our study. So the data from this study was sufficiently good. There were a little over 50 patients done at multiple centers around the country. And the company submitted this data to the US FDA. And 18 months ago, the FDA approved being able to treat the other side with a 9-month delay, meaning you have to wait a minimum of 9 months after the first side is treated to treat the second side. The results of the study took a while to publish for a variety of reasons. That just came out about 2 months ago. I was fortunate to be the first author of that paper in the Journal of the American Medical Association's Neurology Journal. And here are the results. So when we use our standard clinical ratings, that's what CRST stands for, and there are different components to it. You could see a dramatic reduction in the tremor in the 2 parts that measure the actual tremor. What was most impressive to us was that in the third part, in the bottom panel, this CRST-C, that is a measure of quality of life. Now, we always had the dogma as surgeons that if you treat the dominant hand, if you're right-handed and you're shaking like crazy, you make that better. You should be able to drink from a cup, write with a pen. Your life is much better. And that is true. And these were all patients who had their dominant hand, either their right hand if they were righties or their left hand if they were lefties, that were treated the first time. And yet, when we treated their other side, their non-dominant hand, they had an additional 73% improvement on average in their quality of life scores. This shows you how important the second hand is. And for any of you who have tremor on both sides, you know that even if we fix one hand and we make your life considerably better, the fact that the other hand is still tremoring can make doing things that require 2 hands extraordinarily difficult. Using utensils, carrying things. In today's world, right, using a cell phone or something like that, even if the hand that you're tapping with is now stable, the hand you're holding the phone with is shaking, makes your life more difficult. So there are many things in the modern world, as well as traditional things, where having both hands treated can make life even better for a lot of patients. And there was enormous demand amongst our patients to do this, which is why we did this study. So we showed great efficacy, both objectively in terms of the improvement of the tremor in the non-dominant hand, but also the improvement in quality of life score shows how much it meant to these patients, how much it improved them. And this just shows you, this was at the 3 months, which was the so-called primary endpoint, but these data held out to a year. And there's a continued long-term study to continue to follow these patients long-term. I can tell you, I see patients, I just saw a patient today who I treated 7.5 years ago for the first sided tremor, and it's still under great control. And we're now going to do the second side because it has gotten worse over time. So that's how stable we're seeing this. I know there's a lot of things out there on the internet that this can get worse after 3 years or 4 years. We just don't see that in a lot of our patients. We have some isolated patients that have unusual late recurrences, but it is a very small number in our practice. The vast majority of patients either have good, stable, long-term control, and those that do recur usually in the first few weeks, as I told you earlier. The late recurrences at 2 years, 3 years, 5 years are much less common in our practice. They happen, but they're much less common. So we have patients that are stable out to 7 or 8 years now, and we're still even treating their other sides. And now that it's been FDA approved in our clinical practice, we've been treating a lot of second sides, and the results have been very similar to what we saw in the study. So this shows you the stability of all the different subscores. And again, this is the quality of life score, that C part, that 3% improvement at 3 months stayed 75% at 12 months. That improvement in the quality of life stayed over time. Another thing is that about 20% of patients in our study, even after their first side was treated, still had a demonstrable head or neck tremor. And a lot of patients with essential tremor have a real head and neck tremor. Some are mild, and it's just more of an embarrassment or annoyance, and some are really quite severe. And so for those patients that had a head or neck tremor, when they enrolled, this is after they had their first side treated, when they enrolled to get their second side treated, there was about a 70% improvement. About 70% of patients had a real improvement in their head and neck tremor. And we know this historically, that when you do brain stimulation or other things, really the midline tremor in the head and neck requires both sides being treated to get the optimal effectiveness, even though you can get some benefits from just treating one side if it's mild. And again, for those patients that had some ongoing medication because their left side was so bad, or their non-dominant side was so bad, we also saw a reduction in their medications, although that was a small number of patients. Now, in terms of side effects, there were some patients who had some minor changes in their speech or swallowing, most of which was pretty mild. If you look at baseline, there were some patients that already had abnormalities. And the problem with this study was that we did very exquisite testing, formal testing of speech, of various components of speech and swallowing. But that was not done on these patients before their first side was treated, and it wasn't done in the prior studies. It wasn't done in these patients before their first side was treated because most of these patients had their first side treated just in routine practice. They weren't part of a study. And in earlier studies of just treating the one side, nobody did this level of testing. So as you can see, there were some abnormalities at baseline that were not really affecting the patients very much, because one of the criteria was supposed to be that the clinician did not feel that these patients had substantial deficits when it came to speech and swallowing to enroll in the study, but there was no formalized criteria. So even though they got enrolled based on the clinician, the neurologist or the surgeon's general evaluation, when they did formal testing, a lot of patients had some abnormalities that may have been due to their first side treatment. It may have been due to just they had these things in their normal life. It may be that, to the nature of the testing. And so there were some that had some deficits long-term, but again, these were less than 10% in most cases, and they were mild and did not make a major deficit for these patients. And same thing with walking problems. There were a small percentage that had some unsteadiness that persisted at 6 months. But among those that persisted, it was all categorized as mild. And there was a definition. Mild, moderate, and severe were not up to the discretion of the investigator. They didn't say, well, that seems mild to me. There was an actual definition. Mild was that the patient was defined as the patient had some unsteadiness, but they did not require any assistance. They didn't require a cane or a walker or the assistance of another person to be able to mobilize and live their life. That's what mild meant, meaning that they were able to function independently without any assistance. So that's the sort of what was persistent in a small number of patients. So generally, this was not terribly different than treating just one side, and that's why the FDA approved it, and why we've had such strong demand for this. Doesn't guarantee. Some patients may not be candidates for the second side even after their first side was well treated, but most should be. So why might focused ultrasound not be appropriate for a patient? Well, about 10% of patients, their skulls are just not favorable to let the ultrasound go through. And so if your skull density, which is the firmness of your skull, is actually too low, it can be difficult to do this procedure because the skull will absorb all of the energy and it won't get through the skull. If your skull is very firm, very dense, then the ultrasound will just bounce right through and you can get enough energy in. And so that can make the procedure difficult. It's not impossible. If your density is low, you should talk with your practitioner, but in general, that can be a warning sign that there might be trouble in terms of completing the procedure. If somebody is excessively claustrophobic, this does have to be done in the MRI machine. Having said that, I have had many claustrophobic patients that we have been able to get through by just going in for a few minutes at a time, doing what we have to do, and then sliding people out and giving them a break on the table outside of the magnet. And most people have been able to get through this quite well with that, but that is a concern that you might not be able to complete it. Some centers will give people some sedation. I personally just don't like to do that because this is a procedure you want done once and then hopefully never have to do again, never have a problem from it is the hope. And to me, when you give people sedation, it can influence the tremor. It can make the tremor go away. It can make the speech a little slurred, etc. And I just personally am not very confident in doing it that way. So I am kind of a purist in this regard, and I really try to push patients through. But that's why I think our results have been quite good over the years, both in terms of effectiveness and safety. If you cannot get an MRI because of a particular implant that is incompatible, that does not allow you to get an MRI, certain types of old heart valves, for example, or other things, then we simply can't do this because it has to be done in the MRI machine. There are certain implants, certain devices that could be switched. If you have an old spinal cord stimulator, let's say, or even pacemakers that might have been put in years ago, they can be changed to MRI compatible devices. And I've had patients that have done that, that have spoken with their cardiologist, for example, and had an old pacemaker changed to a more modern pacemaker, and then we could do the procedure. But there are some devices that simply, a heart valve can't really be replaced if it's incompatible with the MRI. If you cannot lie flat for an hour and a half or 2 hours, we can try to put cushions under your legs and do other things, but it can be difficult. If your neck is so stiff or your back is in such a way that you simply cannot lie flat, we are not able to let you stand up during the procedure, so that can be an issue. As I said earlier, the head has to be shaved. It is always a bit emotionally challenging for me when I have to shave the head of somebody. I would say they're mostly women, but I don't want to sound sexist because men can have long hair, but somebody who's been growing their hair for their whole life and now I shave it off. But that's something, but it does grow back, and that is an issue right now. And so that's something that you have to be aware of. And then if you have something that could be seriously worsened by the focused ultrasound. Now, again, that's a qualitative thing. If you have walking and balance problems that are quite severe, we're worried that if we could make that a little worse, that could be a real problem. But I have treated patients who are in wheelchairs. I've treated patients who use canes to help them walk because of walking problems from spinal issues or balance problems or other things in advance. And we just talk it out, and we do this carefully, and they understand that they could be worse, and we work through it. And in general, most patients have gone back to wherever they started before the procedure. So that is it. We've been 45 minutes. I don't want to keep people too long. I'll just spend a couple of quick minutes just showing you some cool things that are not really FDA approved right now, but that are just interesting. And one in particular is there are some other areas that we are working on in terms of ablation. So there is an FDA approved indication for Parkinson's called a pallidotomy. That is an area, excuse me, that can help with tremor but it's not as good for tremor, but it can be very good for freezing and stiffness and what's called dyskinesia in patients with Parkinson's disease, which is an involuntary movement in response to medication. That is FDA approved, but we are only allowed to treat one side of the brain. So we have done some patients with this procedure who either are very unilateral, meaning their symptoms are mostly on one side, or they have various medical issues that would prevent them from getting brain stimulation, and where a one-sided procedure may not be optimal, but it's better than nothing. And so that is an option that can be discussed. And then there's a study that has just been completed based on a pilot study that was done initially for another area called the pallidothalamic tract that might achieve a similar result. That was done on both sides of the brain, and that data is currently being analyzed. So I can't really talk much about it because that data is not public yet. It has been public that we've done this study. There have been presentations on the study. And that, again, was a multi-center study where one side was treated, then you had to wait a few months, and then the other side was treated if the patients did well. And so that may be something that's coming down the line, probably sometime next year, but hopefully we'll be able to discuss the results publicly in the next few months. And this is an example of that procedure. And then finally, something really interesting that's not really relevant to treatment right now is the ability to use ultrasound instead of ablating or destroying tissue to do what's called open the blood-brain barrier, where we can, the blood vessels in the brain prevent things from getting into the brain, like viruses and bacteria, et cetera. And so they have a very special barrier that prevents things from getting in. But that's why a lot of drugs and other things can have difficulty getting into the brain, especially new therapies like gene therapies and cell therapies that involve very big things that have to be delivered. So what if you could do that without surgery, without injecting things in the brain? So the idea is that you can use ultrasound with these little bubbles that go in the bloodstream that are normally used for imaging of the heart. And they can bounce around and actually literally punch little holes in the wall of these small blood vessels that don't cause bleeding or cause any serious problems. But these little holes will allow things to pass through. And then within about a day, those holes repair themselves and close up, because you wouldn't want to leave them open indefinitely because that could cause problems. So that gives you a temporary window to open things up. So one application of that is to try to clear out abnormalities in the brain. And we did this in a clinical trial with Alzheimer's disease based on some animal work that you see here that showed that if you just do that, if you just open these vessels temporarily, you can clean out some of the Alzheimer's pathology that normally occurs. And so my colleague Ali Rezai and I did this. Some of you may have seen him on a 60 Minutes piece a few months ago. He's also using this in a different way to try to treat drug addiction, opiate addiction, and we're about to start and join in on that study, hopefully in the next month or two, because we work together quite a bit on things. So here we did this study looking at Alzheimer's disease, and you can see here that we opened where those arrows are, we were able to open the blood-brain barrier, and we injected a little dye in the bloodstream. You can see that dye leaking out into the area we opened in white, showing that we successfully opened it up. And it was very well tolerated and safe. We did it 3 times over a period of a few weeks. You can see here as we're doing this is during the procedure, the area that we're targeting. And we published a paper showing that we could actually get a small, it wasn't large, because this is early days, but we could get a small reduction in the pathology, in the so-called beta amyloid pathology that's characteristic of Alzheimer's disease. And so there are a lot of experimental things that we're doing in my laboratory. We have a machine that we use in our laboratory where we're pushing the envelope on new applications, and certainly with all of these human trials. So there's a lot more with ultrasound coming down the pike. And with that, I will just say thank you for everybody joining. For those of us who have an interest in talking to us more, either to find out more information or to talk to us about potentially helping you, this is my name, my nurse practitioner, Kristen Stribing, who runs my practice and basically, is the brains and the heart of our practice for over 20 years. She usually spends quite a bit of time talking with patients in advance to understand your issues and make sure that we can help you. And then I would get involved after that. Martha Pagan, who is my clinical coordinator, is just a wonderful human being and will help move heaven and earth to help people. And that is the number at which if you call that number and ask for Martha, they will put you through to her and she can be helpful to you. So with that, if there are questions, I appreciate, I hope this wasn't too much or too fast, and I'm happy to answer any questions that people have.
Wow, Dr. Campbell, that was amazing. Um, thank you so much for taking time out and doing this and educating the patients. We do have about quite a few questions in here, so we'll go ahead and get started answering those. And for those of you that are on, if you have questions that you've been thinking about and haven't put them in yet, feel free to go ahead and type them in. And Dr. Caplet's going to stay on a little bit longer just to answer these as best he can. Okay, so the first question
I do
is
have one limit, which is it's my wife's birthday today, so I'll stay on as long as I can, but I can't stay for an hour.
no,
No,
I
I know,
figured
I'm
that we
just
would need
kidding.
to be done in 9 minutes. Is that
No,
right?
no, 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 no,
Oh,
no.
okay.
I'll answer anything people want. Go ahead,
Okay.
please. You
Okay.
understand.
Like we don't
She
want to
knew
get
what
you
she
in
was
trouble,
getting.
Dr.
She knew what she
Kaplan. We
was
don't want to
getting
get
when
you
she
in trouble.
married me. So go ahead.
Okay. So the first question is ultrasound considered an experimental process?
So not for everything up until the last 5 minutes of what I described to you. Everything that I described to you when it came to the ablation procedure for tremor, treating one side and ablating or destroying the small area that's responsible for tremor, that is not experimental. That has been FDA approved for about 7 years. Treating the second side of the brain has been approved for about 18 months. That is not experimental. That is FDA approved. The pallidotomy that I told you for Parkinson's disease, for people who have complications of medical therapy or slowness in freezing, that is FDA approved for treating one side of the brain. That's been about 2 or 3 years, I think. So all of those things are FDA approved, and there are more things that we believe will be coming down the pike soon. There are certain private insurance companies, not Medicare, which approve this, and most private insurers have approved paying for this. There are certain private insurers that still will claim that some of the things that I just mentioned are experimental and they will not reimburse it. And these are things we try to work through. It is one of the quirks of our healthcare system, which is an entirely different conversation that I cannot get into today, and which gets into a whole series of politics that I don't even remotely want to touch with a 10-foot pole. But one of the things that is very difficult for people to understand, and it's very difficult for us as practitioners to understand, is that just because the government approves something for use and allows it to be used does not mean that insurers have to reimburse for that or cover it. It just means we're allowed to do it. And they can still claim that something is experimental, even if the FDA has approved it, and even if there have been many clinical trials, definitive clinical trials that have proven effectiveness. And so if you happen to have an insurer that is denying one of the procedures that I just described, saying it is experimental, your clinician, or if you're working with me, my office, should know how to go through this process to help you appeal, provide the documentation, all of the papers, many of which I've been a participant in or led, but all of the papers that have been published, we provide them to the insurance companies. We provide the FDA approval. We provide documentation in the chart of your note of why we feel you need this procedure and why it's appropriate. And most of the time we can overcome those things nowadays. It's easier now than it used to be. But that is the one issue that people sometimes still face with certain insurers.
Great, thanks. So a couple of these questions, you did touch on it, but I don't know if we want to just go into it just a little bit more. This next person is asking, what can you do or what do you do for someone that is claustrophobic? And you touched on that, and you were saying you weren't going to put them under or whatever. I'm assuming you've had patients in the past that were.
Yeah.
How do you work with someone like that?
The way I do it is I will just take my time. So if somebody is so claustrophobic that they cannot even go into the MRI machine for even a minute, it's probably not the right procedure for you. I would prefer to do deep brain stimulation in that case. There aren't that many people who are so claustrophobic that they can't even go in for a few minutes. If you can tolerate being in the MRI tube for a few minutes, then likely I can get you through, because I don't need you in there for more than a few minutes at a time. It is potentially possible. I am very much opposed to this, but if in the middle of a procedure, I've not had to do it yet, but if in the middle of a procedure, someone was so claustrophobic that we were halfway through and they just could not complete it, we could provide some short-term sedation to try to get through it, but there is a real risk to doing that, because we then don't have immediate feedback from the patient as to whether or not we're making their tremor better. So you give them a little sedation, you do an ablation round, you slide them out, You let them wake up and now the tremor is better. Is it because of what I just did or because of residual effects of the sedation? That's hard to know for sure. And that could increase the risk of recurrence, even if it looks good. Even if you wait it out for 15 minutes, there can still be residual effects. And same thing with side effects. If I'm ablating while someone is asleep, then it's difficult for me to be certain whether I've done something that might have made them worse when it comes to their speaking or their sensations. So again, we can do that, and it's plausible, but I much prefer to try to just help, encourage people through it, take our time. Normally it takes about an hour and a half total going in and out. But if it takes 2 or 2.5 hours, because I'm taking people out more frequently or giving them longer breaks in between rounds, I am more than willing to do that if it helps get somebody through this procedure safely and effectively, if I can avoid doing things that I think are going to compromise the procedure.
Great answer. And again, you did touch on this as well, but this person's asking about voice and neck tremor. So if that's their main issue, maybe we touch on that.
Yeah.
You know, because I mean, we touched
Well,
on
if that's
it,
the main issue, which is unusual, but if that's the main issue without any arm tremor at all, it can be a bit of a challenge because, yes, we need to do both sides. So you could do one side, wait 9 months, and then do the other side. But the question is, if you do the first side and you don't have any measure that you're better from the first side, because it's only, if you only have a head and neck tremor, and let's say we do a good looking ablation, but that's the head and neck tremor is not better, we might say, well, we've done enough and it's not better because we need to do the other side. We'll do it in 9 months. But now let's say you do the other side and you can't get the control you want. Is it because you didn't do enough on the first side or not? If you have an arm tremor with a bad head tremor, and I get the arm tremor completely under control, then I know I've done a pretty decent ablation. And then if you still have a bit of a head tremor, I'm pretty confident that when we do the other side, as our data showed, you have about a 70% chance of getting your head and neck tremor under great control when we do the other side. So when it's a head tremor in isolation, you can consider doing this. You just have to accept the possibility that you might not have as good of a result if you do it just for head and neck tremor because of this issue of getting the immediate feedback when you do one side at a time. But if you have it in combination with an arm tremor, the likelihood is that over time, by doing both sides in a staged manner, that you should have a good chance of getting that under control.
Great answer. Couple questions in here about age limit. Somebody saying they're 86, wondering if this disqualifies them. Somebody else asking if there is an age limit. So can you touch on that a little bit?
I'm sure there is an age limit, but I haven't found it yet. So I have the oldest patient I've ever treated is 93 years old, and he still went home an hour after the procedure. To me, it is all about safety, not age. Okay. I don't want to sound philosophical, and when people talk about that age is just a matter of, it's just in the mind or something like that. There's no question that the body changes with age. There is no question that most procedures have greater risks with age. So older patients will have various medical issues. They can have a higher risk of having diseases like atrial fibrillation or other things where they need blood thinners. And most people are, I'm doing this, most people are still stopping blood thinners for the procedure, but unlike invasive surgery, I will restart it very soon after the procedure, only 1 or 2 days later, just like when people stop it for dental work or colonoscopy. The reason I haven't yet been brave enough to treat people through blood thinners is because not only am I concerned about a tiny bit of bleeding in the brain becoming a problem, but also when you take these pins out of the scalp, they can bleed like crazy if you can't clot off. So I still stop blood thinners, but I restart them quickly. Aspirin, I'm willing to consider doing that through alone. But older patients are more likely to need those things than younger patients because our bodies have diseases when we get older. And various other things that happen to older people can have more lung problems, and breathing problems when they lie flat. Older patients can have more spinal problems and have more difficulty lying flat. So I look at the patient. And if you're older, but you have manageable issues where I think you can get through this, to me, there's nothing inherent about your age that would reduce your likelihood of having a safe and effective procedure as long as you don't have medical problems that go along with your age that could affect your risk. And that's why we've done a lot of patients in their 80s, even their upper 80s. And like I said, some into their 90s. I haven't gone above 95 yet because I haven't had the occasion to. And I'll see when that happens. But
Yeah,
so far, I don't view age as a limit for this procedure.
perfect. Okay, so there's a couple questions here. This person's saying they have intention tremor. Does this treat for that? And they've been told that their tremor in their vocal cords is caused by the thalamus in the brain.
Right.
So she's asking if this focused ultrasound would treat her.
Yes. So this is designed to treat intention tremor. I refer to it as an action tremor. Intention tremor is similar. It's when you go to move, is what an intention tremor is. So absolutely, this is designed to help treat that. When it comes to the vocal cords, they're part of the discussion I had earlier about the head and neck tremor. A voice tremor is part of the whole thing. So that 70% reduction that I showed you earlier when we treated the second side was combining all patients who have a head tremor, neck tremor, and voice tremor into one category. So we do see improvements in those things because it's the same area of the thalamus. You're absolutely correct in saying it's the thalamus. The same area of the thalamus that we're treating for your arm is responsible for the head, neck, and voice tremor. I will admit that sometimes it can be a bit more challenging to get really good control of the head and neck tremor and voice tremor than it can be the arm tremor. But usually we've seen when we wind up doing both sides, we usually see a nice improvement in most, not all patients, but in most patients. The arm tremor, I've only failed once in 8 years and several hundred patients. I've only failed once to get control of the arm tremor right after the procedure. As I said, we've seen about a 10% recurrence rate, but we've only failed once, which is literally a 99 point something percent success rate immediately after the procedure. With the head and neck tremor, it's not quite that high. As I showed you, it's more in the 70% range. So it's a little more difficult, but still quite successful.
Right. Someone asking they have a watchman in their heart. Does this disqualify them?
No. So that's an issue because I was trying to understand that. But the Watchman, to my understanding, is MRI compatible. And so we have done patients who have the Watchman, and I believe it's MRI compatible, and that's been fine.
Great.
But we would certainly confirm that for you.
How long does it take to get in to see you? And then how long does it take to actually have the procedure?
So getting in to see me, that's always a frustration for me because sometimes patients will tell me they've been told that it takes 2 months to see me. I will see anybody, okay? So if you call my office and say you were on this webinar and you want to see me, and if my nurse practitioner feels that you're an appropriate candidate for us, that we're likely, because one of the issues for me is that I'm a surgeon, I'm not a medical doctor, so I have a limited amount of time that I can spend in my patient clinic because I'm in the operating room. I'm also doing research, I'm teaching, I'm the vice chair of the department, I have a lot of things going on. So I need to make sure that in order to be fair to the patients that I can really help, that we are likely, it doesn't have to be a guarantee, but that we're likely to be seeing patients, that we're seeing patients that we're likely to be able to help. It doesn't have to be a guarantee. So that's why my nurse practitioner usually will have a conversation with people on the phone before you come to see us to make sure that you wouldn't be better served by a neurology appointment, let's say, because you haven't necessarily been optimized on your medicines, et cetera, or you may have some other disease that needs to be diagnosed. But she will reach out to people very quickly, and once we feel that it makes sense, I'll see people within a week or two if you want, and if there's an issue, let them know and reach out to me because we're trying very hard to see people quickly. Again, I may be away on a trip. I give lectures all over the world. So I don't want to, I know this is being recorded, so I don't like being recorded saying I'll see people in a week or two. But that is really my intent, and we try very hard. So I normally see people on Mondays in my clinic, but I will often take time on other days when I'm in the operating room or doing research or academic things or on a day when I'm doing ultrasound procedures and find some time to see a patient or two. So I try very hard to see people early. Once we see you, it's usually about a 2-month wait to do the procedure. Part of that is because you have to go through certain things. We have to arrange the MRI and some other things, and part of it is just the amount of time that we have available on the machine.
Great. This person's saying they hate how their medicine makes them feel. And if they have this done, is there a chance that they would be able to stop taking their medicines?
Absolutely. That's one of the main reasons we do this. As I showed you in the slide earlier, most of the patients, when we did the second side, who were still on any medicine, had that medicine reduced. What I didn't show you is how many patients, when we treat the first side, have their medicines reduced. The problem is, if you have a very severe tremor on both sides, then even if you have complete control of the tremor on the one side, it may be difficult for you to reduce or eliminate your medicines because it's still necessary to help your untreated side. But if your untreated side is very mild, or if you don't care, you can reduce your medicines right away. If we get good control, most people don't need their medicines to maintain their control. Some patients will have better control combining the treatment and their medicines long-term, but the vast majority of people don't need their medicines if we get their tremor under good control from the procedure. Now, if you need the other side done, then I usually recommend to people that they stay on their medicines until we get to do the other side, and then we can start working them down. But some people will try to work them down. The only thing is that you can't just stop your medicines, because most of these medicines are often used as anti-seizure medicines. And so if you just suddenly stop it, the brain is used to it and you can actually have a seizure. So we gradually taper and lower the medicines over a 2 to 3 week period when we get it down. But most of our patients, we can get their medicines down or off as long as they don't need it for the other side.
Great. So we have one question left, and it's kind of funny. So I saved it for last.
What?
This person said, you have to shave your entire head completely with a bunch of question marks. So can you just explain why that is?
Right. So just to be clear, I'm not shaving my head completely. I'm shaving your head completely. So I would never shave my head. No, I'm just kidding. The reason, yes, we do. It's interesting. When I was a resident, which was a long time ago, about 30 years ago, we used to shave everybody before surgery. So I got quite good at shaving heads. And then over the years, we really stopped doing that in neurosurgery. So when I do routine brain operations, including deep brain stimulation, I don't have to shave the whole head. We'll just shave a little bit in the area that we're going in. And we found over the years that that doesn't affect the safety of those procedures. But for the ultrasound procedure, the reason we have to shave the whole head, not just with a clippers down to a buzz cut, but literally with a blade and shaving cream to be smooth. The reason we have to do that is because the hair follicles can affect the pathway of the ultrasound beams as they go through the scalp and into the brain, and they can unfocus them, they can scatter them. And you want all of these beams of ultrasound to be staying along the path that it was intended so that they all stay focused on the spot in the brain that we want to hit, and they don't scatter and affect other areas of the brain that we don't want to affect. So that's why we need to shave the whole head that way. As I said earlier, the company is working on ways in which the technology can be improved to try to eliminate that, but that is not happening anytime soon for ablation procedures. So yes, you do have to shave the whole head. You can wear anything you want after. You know, I've encouraged a lot of people, if you don't want people to know, then start cutting your hair short and then maybe wear a wig or something before the procedure. No one will ever know that it's just a change in your hairstyle. A lot of people don't care and they're happy to do it. You know, a lot of people are shaving their head in the world these days. It's a kind of a style. What I tell people is, if your tremor's under control and your head shave is good, go out and buy a motorcycle, get a tattoo, and enjoy your head shave. But it will grow back. We've never seen it not grow back. I can't promise because I'm not in that business, but you know, most people it grows back.
Perfect. Great answer. So we are all done. We have all the questions answered. Somebody just said, thank you so much. It was useful and reassuring. So just want to say thank you again, Dr. Caplet, for your time. Obviously, you're very busy and appreciate that so much. And would you like to close out the webinar?
Yeah, no, I appreciate everybody taking the time this evening out of your schedules with your families and with work and whatever else you may have to do to listen to me. And again, please, if we can be of any help, please reach out to us anytime. And that's regardless of whether we ultimately treat you or not. I've been in this business a long time and we're happy to help however we can. I do hope this was useful and mildly entertaining, but at least useful to most people. And I look forward to helping anyone that we can with this. And I want to thank you guys for asking me to do this webinar, because I think this is important, this type of outreach to help educate people, particularly given today's world where you hear a lot of things from a lot of different sources. you know, we've been doing this longer than most people in the country around the world. There's a few that have been doing it longer than us. And like I said, we've been leading a lot of the studies and doing a lot of this. And so I think being able to hear from our long and extensive and motivated experience, I hope will have helped some of you here. And I appreciate the time. Thanks very much.
Great. Thank you so much, Dr. Caplet, and happy birthday to your wife.
Thanks very much.
All right. Have a great night.
Bye-bye.